was not only a great surgeon and a teacher who mentored all of us, and he was also a person who showed us how to practice ethical medical practice. And he's a very simple man. I'm indebted, thankful to her family who is here. And all this, our attempts, conducting big meetings, everything is possible only because of his support. Like the foundation of this association 9 years back, it was because of him we could do that. With these few words, I invite Guilherme Pagin for the oration. Sir, please come over to the dais. So this is the first Dr. Iqbal Memorial oration I think we'll be doing every year. I invite Dr. Madhu Murali to introduce the speaker.
This is a citation regarding the oration. The citation says, Dr. M. Iqbal Ahmad Memorial Oration 2024 is being herewith bestowed upon Dr. Guilherme. Dr. Guilherme was born in 1983 in Brazil. He earned his medical degree from the School of Medicine at the University of Sao Paulo, Brazil, and he received his licensure for the practice from 2008. He pursued his residency in general surgery and further completed his residency in coloproctology. He completed clinical fellowship in laparoscopic surgery and coloproctology from the Angelita Habergama Institute, Sao Paulo, Brazil, where he is currently serving as a colorectal surgeon. He received board certification from the Brazilian Board of Surgery for the alimentary tract surgeries in 2015 and colorectal surgery in 2016. As a colorectal surgeon at the Angelita Habergama Institute, he has made immense contributions to patient care, pioneering the concept of wait and watch, or organ preservation rectal cancer surgery. This has given a new avenue of stoma-free life to many patients, has dramatically improved the quality of life of cancer survivors. He has made enormous contributions to medical literature and science through 83 publications which he and colleagues has brought out from the Institute. He is the winner of several prestigious awards such as the Robert Beat Impact Paper of the Year 2022, the Robert Madoff Scientific Achievement Award, and the Barton ICRS Best Video Award. He is married to Rachel and is the father of 2 children, Anna and Joa. Recognizing his contributions to patient care and to medical sciences, the Kerala Association of Surgical Oncology here bestows the prestigious Dr. M. Iqbal Ahmad Memorial Oration 2024 on Dr. Guilherme.
Hi, good morning, everyone. It's a really honor and privilege to be here, to be honored with this oration. Dr. Iqbal seems to have been a really important surgeon and person in this country, in the world. And I'm really honored to be here today giving his oration. Okay. There we go. So I was asked to talk a bit on watch and wait in locally advanced rectal cancer. What are the lessons learned so far? And it's a subject, as mentioned, that I enjoy very much talking about. And I hope we have a very good few minutes here talking about it. So this is my disclosure. I used to give talks to Johnson & Johnson, but perhaps my main disclosure is that I am a big admirer from this lady who a few years ago came up with the idea of watch and wait. And to talk a bit about watch and wait, I need to tell you what she told me. So if you allow me, I will tell you a short history she told me a few years ago. So by the early 90s, she was the head of the colorectal department in the University of São Paulo in Brazil. And she was treating a young lady with a rectal tumor who had the neoadjuvant treatment and then had the operation, standard operation, Miles operation, with a terminal colostomy. End up that this patient had a pathological complete response. And by the time Professor Angelita come to this patient and say, look, I'm really, really happy. The chance you cured is extremely high because there was no tumor in the specimen we removed. The patient looked at her and said, thank you so much, Professor Angelita. So you're just telling me I'm gonna live with this stoma and you did not remove one single cancer cell from me? Probably the majority of us will go home and say, well, I've done my job, but not this lady. So she said, I think I can do better. I think I can do the difference for this patient. And a few years later, in the United States, they did a survey and asked patients, what are their main concerns regarding rectal cancer treatment? So this was asked to patients with rectal cancer. And if we look carefully, the most important things for this patient is not having a stoma. It's side by side to being cured. So it was not only that patient. Probably all patients are concerned about having a stoma. And we need to take this in consideration. If we know that patients with rectal cancer, low rectal cancer, had a really high chance of end up with a terminal stoma in the follow-up of 10 years, even if we don't start with a stoma, we do in colorectal anastomosis, this patient will end up with a colostomy not in a small proportion of patients. So all of this together makes us think that we need to think about watch and wait. So in the beginning, long-course chemoradiation was the standard treatment for locally advanced rectal tumors, basically because it was associated with a lower chance of local recurrence. We had nasty tumors like this one here that would go long-course chemoradiation, and the thing is, some patients would have a clinical complete response. And then the question is, do we need to operate this patient, or can we just watch and wait this patient? What would happen if we just watch and wait this patient? So to start talking about watch and wait, we need to clearly define what is a complete clinical response. So clinical complete response is defined based on 3 assessment tools. The first is digital rectal examination. Digital rectal examination reassessment needs to be clear, no irregularity. Take your time, feel the rectum, look for it, be obsessed for it, trying to find anything wrong in that rectum. If there is anything there, then this is a complete clinical response. Apart from clinical examination, we come to endoscopy. In endoscopy, we don't need to see anything. That's the thing. Should I biopsy? You don't have anything to biopsy. You can see a whitening of the mucosa, some telangiectasia, but look carefully. Don't just take a picture, look at a bad picture to say this is a complete response. Look, use MBI, use near focus, try to find something, be obsessed, and be sure that this is a complete response. If nothing is there, then we're dealing with a complete response. Once clinical and endoscopic assessment is done, then we move to the radiological assessment, and we're gonna have the MR as the main tool that will be crucial to assess the rectal wall and the mesorectum and pelvic side wall to look for any tumor deposits or nodes that may be residual, which is quite unlikely, but it may happen. Once we have all these 3 assessment tools saying it's a complete response, then I'm dealing with a complete response and I can include this patient in a watch and wait protocol. If not, we need to be careful. Because sometimes we're dealing with this. We look and there is something there. MR there is no tumor, PR we don't feel anything, but on endoscopy there is this small ulcer. What should I do? Should I biopsy it? And the answer is no. Well, you can biopsy, but you should not trust your biopsy, because a negative biopsy is usually wrong. What does it mean? If there is something there, you don't need a positive biopsy to do something. Does it mean that we need to operate this patient now? No, it does not mean. We know that timing perhaps is the more important than the biopsy. So this is a paper we published 5 years ago and was this year awarded as the most relevant paper on DCR in the last 5 years. And it showed that patients take time to achieve a clinical complete response. So if we're dealing with this kind of patient that we suspect is a complete response, but it did not meet all the 3 criteria yet, we can further reassess this patient. Reassess in another 6 to 8 weeks with all the 3 assessment tools. If then I have a complete response, well, this patient is the one to be included in the watch and wait protocol. This patient is what we're looking for. So this is what we're talking about. It's what we called accidental watch and wait. Accidental, why? Because we did not do chemoradiation because we were aiming for a complete response. We did because we thought it was a locally advanced tumor that need chemoradiation for local control, and end up that the patient had a complete clinical response and we put it in on a watch and wait pathway. What happened to these patients? Well, they have very good results. So in the beginning, it was quite hard to publish anything or to demonstrate, to make the world believe that watch and wait was acceptable. But after a while, we have data from many institutions, and this is a systematic review with meta-analysis that demonstrate that watch and wait had similar oncological outcomes than patients operated with a pathological complete response, and also to those patients operated after clinical complete response. That the truth is, clinical complete response is not the same as pathological complete response. It's not the same because sometimes the tumor will regrow. If we have a local regrowth, then we need to be concerned. Now we start to be concerned. That's why we need to be obsessed with local regrowth in all patients we're following in a watch and wait protocol. We cannot just come for a follow-up, straight follow-up, do it on 2 seconds, send home, back in 2 months. No, you need to be obsessed. Try to find a local regrowth because it can happen. And usually, look here, 95% of the local regrowths are assessed to the finger. That means that the patient sitting in front of you, it does not need any specific test or high-resolution MR to diagnose the local regrowth. Just need a proper digital rectal examination, and you will make the diagnosis of a local regrowth. And now, what to do? So, local regrowth, what's the incidence? How often does it happen? Around a quarter to a fifth of all watch and wait patients that previously had a clinical complete response will have a local regrowth. Can we anticipate which patient is at higher risk of having a local regrowth? Yes, we can. And the only risk factor to having a local regrowth is having a baseline T stage that's 3 or 4. So early tumors like CT2 tumors had a much lower chance of having a local regrowth after a clinical complete response. This is the data that we initially saw at our numbers. You can see that's not that much of patients because it's not that much of patients that will have a local regrowth, but it happens. When we look at larger numbers, again, T stage is the only risk factor for having a local regrowth. So if the tumor was initially a T2, the chances are much lower of having a local regrowth. If the tumor was initially a T4, then we are really concerned about it. Well, this difference will last for 1 year. So this is a conditional survival modeling. What does that mean? It means that if the patient is after 1 year of follow-up and did not develop any local regrowth, after that, the chance of having a local regrowth is not influenced anymore by the initial T stage. So the initial T stage influence in the first year of follow-up and not on the following ones. And for how long should I be concerned? Forever? Well, not forever. So again, using conditioning survival modeling, we know that patients after 3 years without any local regrowth has a very low risk of developing local regrowth. So this is a key point. For how long do I need to follow up? Well, as an obsessed guy, for 3 years. So in the first 3 years, these patients need strict follow-up, searching for a local regrowth. Well, what now? This patient had a complete clinical response, and now he had a local regrowth. I've diagnosed it. Can I still do the operation? Is it possible to still perform a proper operation and locally control this tumor? So this is a patient being operated after 19 months from the treatment, and you can see that's no major fibrosis or anything, basically because we're dealing with a small local regrowth. It's different if you are operating a large tumor after 19 months from the radiation therapy, which we do not want to get to this point if we do proper follow-up. So patients operated for a local regrowth had a very high local control, very good local control. So the chance of having further local recurrence after the operation of a local regrowth is around 5%, which is quite good. But what about doing local excision for the local regrowth? So I was asked this in the previous session. The patient has a local regrowth. Can I do a local excision to this patient? Would it be enough? So we compared. So we took our patients and the patients from Portugal. There's an institution in Portugal called Champalimau Foundation that's also doing watch and wait for a while. We joined our patients and looked those patients that were treated according to the strategy used to treat this patient. Patients that were further treated with organ preservation, mainly local excision, or those that went to radical operation. And what we found out is that early tumors, again, had a higher chance of had a local excision after a local regrowth. So we can still keep with an organ preservation strategy for this patient. And what are the oncological outcomes? Well, if we look here regarding local control, of course, this is not a randomized trial. Of course, this is selected group. So we selected the best patients for a local excision and the worst patients or the worst tumors for a radical operation. But those treated with local excision had similar local control than those treated with radical surgery and had better systemic control than those treated with radical surgery. Meaning that if we properly select our patients with local regrowth, yes, we can do a local excision to further do organ preservation to this patient. What about systemic disease? The patient had watch and wait. Is he at risk of having systemic relapse? So a few years ago, a group in the United States published this paper on JAMA saying that patient that had a local regrowth has extremely high risk of having systemic recurrence compared to patient that had watch and wait and never had a local regrowth. When we looked at the International Watch and Wait database, that is a database of patients of watch and wait that had more than 40 institutions around the world, we saw that the only risk factor for having a systemic recurrence after watch and wait is having a local regrowth. So again, local regrowth, the main problem here seems to be systemic disease and not local control. If we look at, again, at the conditional survival modeling, The risk of a patient in the watch and wait protocol have a systemic recurrence after 5 years is quite low, around 5%. But the problem is if this patient has a local regrowth. If we consider patients that had a local regrowth, the risk of having further systemic recurrence after 5 years is quite high, nearly 15%. For how long should we follow this patient? The truth is, we believe having a local regrowth is like having a second hit. It's like having a second primary tumor. What do I mean? When we have the baseline tumor, we had a first hit, the tumor is growing, is spreading everywhere, then we start treating and have a clinical complete response. But there was some residual tumor there that started growing again, and this is a second hit, meaning that while we do not diagnose this residual tumor, he will spread, and this is the second hit. Meaning that by the time we operate this patient, is the time we need to start counting for how long we're gonna need to follow up this patient because he is at increased risk of systemic recurrence. If we look at these curves here, this is considering local regrowth surgery as the start point from counting the time. We're gonna see that the risk of systemic recurrence only decrease after 5 years from the local regrowth operation. So if you had a local regrowth, you need to follow this patient at least for 5 years after the local regrowth and not from the primary tumor treatment. But if we saw what the American paper published a few years saying that watch and wait and regrowth has worse systemic recurrence rates, we perhaps are not considering the proper groups to compare because we're comparing a group that's a complete responder with a group that's an incomplete responder. Definitely is a worse set of patients. Perhaps what we should do is compare patients that were operated by the time of the regrowth to those patients who was immediately operated after the chemoradiation treatment at restaging with an incomplete response. Does these two groups had difference regarding systemic metastasis? So we did this comparison nearly 20 years ago, and there was no difference. Overall survival, distance-free survival, pretty much the same among the groups. And then came the OPRA trial. The big OPRA trial from the Americans again, that randomized patients with rectal tumor to have long-course chemoradiation with TNT, further chemotherapy with CAPOX or FOLFOX, either induction or consolidation. And patients that had a complete response in this trial were recommended to have a watch and wait policy. And they compared the oncological outcomes or the disease-free survival of patients that were operated at restaging after incomplete response and those that were operated after regrowth. And there was, again, no difference. So perhaps comparing to the incomplete responders, we'll see that the local regrowth is not at that risk of having a systemic recurrence. The problem is, I believe this is perhaps not fair too, because patients that have a regrowth, we thought it was a complete response. He had an amazing response. And we're comparing to a group of incomplete responder that had minimal or no response after radiation therapy. That's why they were operated at restaging. Is this fair? I don't believe it's fair. So we decided to do a further analysis. Instead of comparing to all incomplete responders that were operated at restaged, we selected only the patients that were operated and had a near complete response, which probably is the group that had a regrowth. If we had operated this group that had a regrowth at restaging, probably they had a near complete response. To do that, we used our patients and the patients from Portugal and compared to a group from France that do a straight operation for these patients. And what we found out is that patients operated after regrowth, they had worst rates of systemic recurrence. they were at increased risk of systemic recurrence. And the systemic recurrence usually happened later, 22 months compared to 10 months, probably meaning there was a second hit here. We did the same analysis using larger numbers. Again, the International Watch and Wait database using only the local regrowth. And we compared to the Vikingo database, which is a Spanish database that do proper baseline assessment of patients, proper pathological assessment of patients after TME. And we used only patients that had nearly complete pathological response. This paper was presented at ASCO GI this year and showed exactly the same result. So if we're dealing with local regrowth, this patient is at increased risk of systemic recurrence if we compare to patients who were operated at restaging and had a nearly pathological response. And this is relevant for all staging, either from stage 1 disease to stage 3 disease. Then we come back to OPERA. OPERA did a secondary analysis because some patients had a near complete response at assessment, and some of them were included in the watch and wait policy, some were not. And what did they, if we look at the data, this was not properly analyzed, it's just an overview or an overlook of it. Patients that were operated at restaging and had a near clinical response, they had a 15% of systemic recurrence during follow-up. And if we compare to patients that were operated at regrowth but had a clinical complete response, this raised to 30%, which is pretty much the same numbers we've seen with our patients. So if we're talking about accidental watch and wait, what we've learned so far, we've learned that watch and wait is for patients with a clinical complete response. And the clinical complete response is patients that had a clear clinical, endoscopical, and radiological assessment. We know that biopsy should not be considered as a criteria for clinical complete response. You can biopsy if you want, but do not believe on the biopsy to recommend watch and wait for a patient. Regrowths, they happen, they can be salvaged. Local recurrence after local regrowth is low, and the incidence is lower in the early tumors. Some of these early tumors can further be treated with further organ preservation, with further local excision. And what's new and is really concerning us nowadays is that these patients with local regrowth, they had, yes, increased risk of systemic recurrence if we compare to patients with nearly complete pathological response operated at reassessment. And then we come to the new possibilities. So usually we recommend chemoradiation for patients with locally advanced tumor. But we've just seen that those patients with early tumors, early disease stage, had a, well, better success rate in the watch and wait policy. So why not, instead of doing watch and wait by accident, we don't do it intentionally. So we take these patients that have early tumors, so we stage them, they're T2, node 0, and then we look where the tumor is. For those tumors that are really low, so we use the sagittal view to decide this mainly. Tumors that are beyond the anorectal junction or just 1 centimeter above it are the main candidates, are those that will really benefit more from organ preservation, considering the risks I just told you. This patient, we would offer chemoradiation with the intention of organ preservation. And what kind of chemoradiation? So usually we had done the standard treatment for many years, long course chemoradiation with 2 cycles of 5-FU. Sorry. Let's see if I did that. There we go. I'm sorry about that. So if we have an early tumor, we can do intentional watch and wait. That means that we select this patient before the treatment for having neoadjuvant treatment. So patients with early tumors, we select those that are really low tumors where the benefits are higher than the risks, because this patient had a very high risk of having a stoma. In the end of the day, what matters is having a stoma. And we select them for treatment. So what kind of treatment? We used to do the standard long-course chemoradiation with 2 cycles of 5-FU for many years. But then we decided to increase our treatment. And we started this 2006, so nearly 20 years ago. We, instead of doing 50.4 grays, we start doing 54 grays with a boost to the primary tumor. And instead of 2 cycles of 5-FU, we decide doing 6 cycles of 5-FU to see if we can increase the response. And in this paper published, we were looking only at the early tumors, the T2 and 0 tumors. And what we saw is that the rates of successful watch and wait, that means TME-free survival or surgery-free survival, was nearly double for those patients treated with increased treatment with TNT. So nowadays, we recommend increased treatment for these patients that we're aiming for a complete response. But if we look to what the OPERA trial has demonstrated, so the OPERA trial select not only early tumors, but also node-positive tumors, T3 tumors. And in both groups, they had around 50% of organ preservation, which is pretty much similar to what we've done with 5-FU only. And then we came up with the idea, do we really need this oxaliplatin? We all know that oxaliplatin is quite toxic drug. Many patients has peripheral neuropathy. So we decided to draw this trial that's going on South America, driven by us. It's called the CHAO trial, where patients with really distal tumor, those that are candidates to intentional watch and wait, are randomized to have long-course chemoradiation and consolidation chemotherapy in one group with 5-FU plus oxaliplatin, and in the other one, only capecitabine. And the idea is to see if there is any real benefit of adding oxaliplatin for this patient, who in the end of the day is not at risk of systemic disease, but at only doing this treatment for the aiming of having a complete response. The accrual is going quite good so far, but will take some time. Perhaps next time I'll bring the results of this trial for you. So watch and wait, what does that mean? It means obsession. It means that you need to follow up these patients really careful for 3 years with digital rectal examination, endoscopy, magnetic resonance. After that, we can soft a bit. We can do, after 6 months, the protocols. So apart from complete clinical response, biopsies are not relevant. Regrowths happen and can be salvaged but are at risk of systemic recurrence. We need to think on watch and wait before thinking of any other treatment for this patient, especially for the early distal tumors. These patients, when they first come to us, we need to think perhaps this patient is a candidate to intentional watch and wait. And these are the ones that will have the better results because they had lower risks of regrowth and then for lower risk of systemic recurrence and higher risks of being treated with a local excision if they regrow. So to end out my talk, this is something Professor Angelita used to repeat. I don't believe she is the one that taught this, but she repeats very often. So the good surgeon knows how to operate. The better surgeon knows when to operate, but the best surgeon knows when not to operate. Thank you so much for your attention.
I know that most of you will be having several questions to be asked regarding so, but unfortunately, being an oration session, we don't have the protocol for asking questions, but I do believe that we can have questions during the coffee break. So thank you, Chandra Mohan, thank you, Ansar, for chairing the session, and special thanks to Farzana for being with us on this occasion for the first Iqbal Ahmed Memorial Oration. So thank you for the participation, and we come to end the session. One photo, please.